Hello, my name is Professor Isidora Vujcic, and I will talk about impact of COVID-19 on liver disease. COVID-19 is primarily a respiratory disease with multi-organ involvement, including impaired liver function. It has been noticed that a significant proportion of COVID-19 patients have liver dysfunction, especially those with a more severe disease course. Drastic lifestyle changes during the COVID-19 pandemic have led to an increase in the incidence of liver disease. Liver damage in COVID-19 infection occurs during disease progression in patients with or without previous liver disorders and represents a risk factors for developing severe illness and death. Acute liver damage due to SARS-CoV-2 infection is common among COVID-19 patients and is generally mild, transient, and self-limiting. Chronic liver diseases, such as metabolic-associated fatty liver disease, are associated with a less favorable prognosis, especially when alkaline phosphatases show a significant rise. In fatal cases of COVID-19 liver injury, incidence ranges between 58 and 79%. Multifactorial causes of liver damage during COVID-19 infection include direct virus cytopathogenetic effect, abnormal immune response associated with the cytokine storm, vascular changes due to coagulopathy, hepatic ischemia, hypoxia, reperfusion injury, and drug-induced liver injury. The coronavirus causes direct liver injury using the angiotensin-converting enzyme 2 receptor for cellular entry, which is expressed mainly in the cholangiocyte and less frequently in the hepatocyte. Certain hepatotoxic medication, such as antibiotics, antivirals, steroids, and other drugs used to treat patients with COVID-19 are rare, connected with drug-induced liver injury, and were found in 11% of COVID-19 patients. However, in COVID-19 patients, the liver damage is primarily secondary to ischemic, hypercoagulable, and hyperinflammatory states, which are independent predictors of death rather than liver injury per se. A cytokine storm and the massive acute phase response are defined by the acute overproduction and uncontrolled release of the pro-inflammatory cytokines, tumor necrosis factor, interleukin-1 and interleukin-6, paralleled by excessive secretion of C-reactive protein and ferritin. Coagulation dysfunction indicates a poor outcome in critically ill COVID-19 patients with hepatic injury, including a significant role of neutrophils and monocytes in amplifying blood clotting. Host factors of liver injury are presented on this slide, and they include older age, male gender, pre-existing diseases, and liver markers. Older people are prone to develop a more severe COVID-19 and worse liver function. Also, men are more prone to liver injury than women. Liver enzyme abnormalities are frequent in patients with COVID-19 infection, and they are associated with disease severity. The most frequently reported mild to moderate elevation were in aspartate aminotransferase, alanine aminotransferase, and total bilirubin levels, but abnormal gamma-glutamyl transferase, alkaline phosphatase, and albumin levels have been found in patients with COVID-19 as well. Liver damage in COVID-19 is usually temporary, and therefore the enzyme levels of most patients usually return to normal after recovery. On this slide, we can see groups that are at risk of COVID-19 infection, induced liver injury, and those are patients with pre-existing disease like chronic viral hepatitis, cirrhosis, hepatocellular carcinoma, and alcohol-associated liver disease. Then post-liver transplant recipients, patients with a metabolic syndrome, syndrome, including hypertension, dyslipidemia, diabetes, and obesity, and patients with cardiovascular diseases. Patients with certain history may also be at risk, including those who are receiving oxygen therapy or have an inflammatory history. In a healthy population, as we already saw, older people, men, and probably pregnant women are also vulnerable groups. The prognosis of COVID-19 infection depends primarily on the patient's characteristics, present comorbidities, severity of clinical symptoms, laboratory parameters, and imaging features, and we can see it, all of them, on this slide. Pre-existing liver diseases and prognosis of COVID-19 patients. So pre-existing liver disease may have adverse effect on COVID-19 prognosis, including severity, death, and mechanical ventilation. Pre-existing liver disease in COVID-19 patients are usually comprised of chronic hepatitis B and C, metabolic associated fatty liver disease, alcohol-related liver disease, autoimmune hepatitis, cirrhosis, and hepatocellular carcinoma. The prevalence of baseline pre-existing liver disease is low, and it's ranging from 1 to 11%. These patients have higher risk of developing severe COVID-19 and up to 10-fold higher mortality rate. So we can see here the results of a systematic review and meta-analysis, and 25 studies reported the severity of the chronic liver disease and group without chronic liver diseases. The pooled odds ratio was 2.4, indicating that the odds of developing severe disease among COVID-19 patients with chronic liver disease were 2.4 times higher than among those without chronic liver disease. And a subgroup analysis showed that COVID-19 patients with non-fatty liver disease had the highest odds of COVID-19 severity, followed by metabolic associated fatty liver disease and cirrhosis. COVID-19 patients who had viral hepatitis did not have significantly higher odds of having a severe form of COVID-19. Here is the forest plot showing the difference in mortality between COVID-19 patients with and without chronic liver disease. In total, here are the results of 26 studies. The pooled odds ratio was 2.3, indicating that COVID-19 patients with chronic liver disease have 2.3 times higher odds of dying as patients without chronic liver disease, and subgroup analysis was done only for cirrhosis because it had enough studies to give a pooled estimate. It was found that COVID-19 patients with cirrhosis had 3.5 times higher odds of dying as patients without the cirrhosis. Here are results of one study which investigated the impact of COVID-19 pandemic on liver disease related mortality rates in the United States, and the results show that age standardized mortality ratio for alcohol-related liver disease and non-fatty liver disease increased at alarming rate during the COVID-19 pandemic, with the largest disparities among the young, non-Hispanic white, and Alaska Indian Native American populations. Globally, 2 million deaths are attributed to liver diseases, including 1 million due to cirrhosis and 1 million due to viral hepatitis and hepatocellular carcinoma. Over the past 2 decades, the prevalence of chronic liver disease has been increasing. Non-alcoholic fatty liver disease, or the recently defined metabolic associated fatty liver disease, are the most common chronic liver diseases, which affect about 1/4 of the world's adult population. The global prevalence of non-alcoholic non-alcoholic fatty alcohol liver disease has been rapidly increasing in tandem with the rise in diabetes and obesity prevalence, both of which have been associated with increased mortality in COVID-19. The prevalence of non-alcoholic fatty liver disease in COVID-19 patients is 31%, which is higher than the prevalence in the general population. Although several studies show significant association between non-alcoholic fatty liver disease and severe COVID-19 outcomes, there is still no strong evidence that the presence of non-alcoholic fatty liver disease affects its prognosis. The possible reason for the high risk of severity among these patients could be the complex interplay of chronic active inflammatory pathways between the COVID-19 associated cytokine storm and non-alcoholic fatty liver disease. Injury caused by the accumulation of fat in the liver could exacerbate the cytokine storm and worsen the prognosis of patients. In addition, liver fibrosis has been linked with a higher risk of severity among COVID-19 patients. Liver fat accumulation and subsequent fibrosis may be reasons for non-alcoholic fatty liver disease patients' more deficient outcomes. The COVID-19 pandemic probably had the biggest effect on patients with alcohol-related liver disease due to substantially increased alcohol consumption provoked by adverse economic effects, disruption in work and education, and social isolation. Patients with alcohol use disorders are more likely to develop acute respiratory distress syndrome and have additional comorbidities such as metabolic syndrome, chronic kidney disease, and smoking, all of which are independent predictors of COVID-19 severity. Several studies have identified that alcohol-related liver disease is independently associated with COVID-19 mortality after adjustment for important cofactors such as liver disease severity. We can see on this slide the prevalence of hepatitis B viral infection, and on this slide prevalence of hepatitis C viral infection. And so hepatitis B and C are still a major cause of liver disease burden globally, especially in low-income countries in Asia and sub-Saharan Africa, despite the availability of effective preventive measures and treatment. There is still insufficient evidence for an association between previous hepatitis B and C infection and COVID-19 outcome. Most studies that have examined the influence of hepatitis B virus on COVID-19 prognosis have been conducted in China due to the high prevalence of hepatitis B viral infection in the country. The presence of COVID-19 infection or treatment with some drug could reactivate hepatitis B infection. COVID-19 patients with cirrhosis are at a greater risk of adverse outcomes than the background population. Cirrhotic patients have significantly higher all-cause mortality in COVID-19 infection than non-cirrhotic patients, and mortality is probably higher in those with more advanced cirrhosis. The possible pathogenesis behind the cirrhosis patients having a higher rate of severity and that following COVID-19 infection could be the excess systemic inflammation, intestinal dysbiosis, cirrhosis-induced immune dysfunction, and coagulopathies. So, the age-standardized incidence rate and age-standardized mortality rate for hepatocellular carcinoma are highest in sub-Saharan Africa and parts of Asia and income Asia-Pacific. The presence of hepatocellular carcinoma in patients with chronic liver disease and COVID-19 infection was associated with poor prognosis, including a higher risk of all-cause and COVID-19 related mortality. Most hepatocellular carcinoma patients have concomitant cirrhosis, and that could potentially increase their risk of severe COVID-19. Although the presence of COVID-19 infection in chronic liver disease patient is associated with a poor prognosis, including severity and mortality, these results should be interpreted with caution and need to be evaluated in large future studies. Such findings could be explained by overlapping risk factors, therapeutic effort limitation, different etiologies, and disease spectrum of chronic liver disease, which ranges from mild asymptomatic disease to severe decompensated cirrhosis. What is actually impact of COVID pandemic at the liver? The incidence of alcohol-associated hepatitis increased during the pandemic. Hepatitis B vaccination and hepatitis C therapy were among the most frequently disrupted services, and future decompensation and misdiagnosis of hepatocellular carcinoma are anticipated in the coming years. And that would be all. Thank you for your attention.